I want you to take a deep breath in right now and just imagine something incredibly bizarre happening inside your chest. Your lungs, the very organs keeping you alive this second, are not actually physically attached to your rib cage.
You're right. They really aren't.
They aren't bolted down. They aren't glued to the chest wall. They kind of just float there. And they are held open by this delicate, entirely invisible physical trick. And if that trick fails, the whole system collapses. So welcome to today's deep dive.
Thanks for having me. It's a great topic.
Today, we are figuring out exactly how that microscopic magic trick breaks and why doctors have spent the last 200 years arguing about how to fix it. We're looking at conditions where the pleural space gets hijacked, specifically by air, which is a pneumothorax, or by fluid, which is a pleural effusion.
Yeah, and it's the perfect topic for us to explore because it really bridges abstract physics with these immediate life or death emergencies.
Yeah.
But to understand the pathology, like why things go so disastrously wrong, we first have to understand the normal, everyday state of affairs inside your chest.
Okay, let's unpack this. Because before we can understand why a lung collapses, we definitely have to establish why it stays inflated in the first place.
Yeah.
You were telling me earlier, it essentially boils down to like a biological tug of war.
It is a constant, lifelong tug of war. Think about the tissue matrix of your lung. It is packed with elastin.
Okay.
So its natural physiological instinct is to recoil inward and shrink. It's very much like a thick rubber balloon that, actively wants to contract.
Okay.
But your chest wall, so the ribs, the intercostal muscles, the cartilage, it has the exact opposite
Then
instinct.
to go the other way.
Exactly.
Yeah.
The chest wall naturally wants to spring outward. Its resting anatomical position is actually wider and more expanded than where it normally sits when you breathe out.
So you have a lung pulling inward and a rib cage pulling outward. They're basically trying to run away from each other every single second you're alive.
Yeah, and what keeps them yoked together is the pleural space. And I use the word space loosely here because in a healthy person, it's really just a potential gap between two incredibly thin membranes. One membrane wraps the lung, the other lines the inside of the ribs, and between them sits this microscopic layer of fluid, usually just 10 to 20 milliliters for the entire hemothorax.
Okay, if I'm visualizing this, is it basically like two wet plates of glass?
Yes, perfect analogy.
Like if I put a few drops of water between two flat panes of glass and press them together, I can easily slide them back and forth. But if I try to pull them directly apart, they violently resist.
The underlying physics are completely identical. That lubricating fluid allows your expanding lung to slide seamlessly against the rough inside of the ribs every time you inhale. But that surface tension completely prevents the two membranes from pulling apart.
Wow.
And this constant mechanical pulling in opposite directions, so the lung in, the chest wall out, it creates a negative pressure inside that tiny fluid space. We're talking roughly negative 5 centimeters of water pressure at resting baseline.
But wait, I have to stop you here. Because when people hear negative pressure, the immediate image is a vacuum. So wait, so the lung doesn't pop like a balloon, and it's not a vacuum cleaner in there actively sucking the lung outward.
No, and that is one of those common misconceptions out there. It is a mechanical equilibrium, not a suction vacuum.
Oh, okay.
There is no explosive pop if the system fails. If you break that liquid seal, say air sneaks in or too much fluid builds up, that pleural pressure simply neutralizes.
It just goes away.
Right? It rises from -5 towards 0. And without that negative pressure holding the lung against the chest wall, the lung's own internal elasticity just takes over. It passively, quietly recoils inward to its deflated shape.
Like letting go of a stretched rubber band, it just goes back to being a small, dense mass of tissue.
Exactly. And the volume of air or fluid that invades that space directly dictates how much that equilibrium is disrupted, which is why you often see partial collapses rather than total ones. The physics only fail as far as the invading volume pushes them.
So we have this invisible tug of war dictating our survival. But since we can't see this happening inside a living, breathing human chest, how did early doctors ever figure out this delicate seal was breaking? I mean, long before X-rays or CT scans, somebody had to piece this mechanics puzzle together.
They had to get really creative and often highly physical. Going all the way back to around 400 BCE, Hippocrates diagnosed chest issues by literally grabbing patients by the shoulders and vigorously shaking them.
Wait, just aggressively shaking an ill patient to see what happened?
Yeah, quite literally. He was listening for a highly specific acoustic signature inside the chest cavity. It's known as the Hippocratic succussion splash.
The succussion splash.
Right. If you think about the physics of a normal chest, there is no sound because there's no air fluid interface. But if a patient had a broken pleural seal that let in both air and a pool of fluid, so a hydropneumothorax, that mixture would literally slosh around when shaken, like water in a half-empty jug.
That's incredible.
And amazingly, some clinicians still use that physical maneuver at the bedside today when they don't have imaging equipment.
That is wild to think about. A diagnostic technique lasting 2.5 millennia. But fast forward a bit, and the actual term pneumothorax was coined in 1803 by a French physician, Jean-Marc Gaspard Itard. But Itard didn't really crack the code on mapping out these different chest pathologies, did he?
No, the real acoustic mapping came from René Laennec in 1816. He realized you could determine the physical state of the internal organs just by listening to how sound traveled through them.
Right.
And he invented the stethoscope to do it, largely because, well, he felt it was highly improper to press his ear directly and firmly against the chests of his female patients.
So a desire for personal space and modesty revolutionized the way we map human anatomy.
It really did. Laennec spent years rolling up cylinders of paper and later crafting wooden tubes to systematically catalog chest sounds. By 1819, he published this massive treatise linking specific acoustic findings to what was happening in the pleural space. So if he tapped the chest and heard a hyper-resonant drum-like echo, he knew the space was filled with air.
Okay.
If he heard a dull thud and absent breath sounds, he knew fluid had taken over. He even described a metallic tinkling noise associated with specific air leaks.
That acoustic mapping is brilliant. But I want to jump to the late 19th century, 1888 to be exact, because there is a chapter in the history of pleural space mechanics that I just cannot get over. Carlo Forlani, he looks at this terrifying condition, a collapsed lung, and basically decides, let's do this to people on purpose.
Yeah, and what's fascinating here is the sheer clinical logic behind his seemingly insane proposal. Forlani suggested deliberately inducing a pneumothorax to treat tuberculosis.
It was a massive killer at the time.
Absolutely. TB bacteria aggressively destroy lung tissue, creating these large bleeding cavitary lesions. Forlanini hypothesized that a diseased lung could never heal if it was constantly expanding, stretching, and pulling apart those lesions, 20,000 times a day with every breath.
Wait, so they intentionally recreated a fatal emergency just to force the lung to stop moving? How did they manage to do that without just killing the patient outright?
By meticulously controlling the physics we just talked about. They didn't collapse both lungs, just the infected one. And didn't do it all at once.
Okay.
They would inject carefully measured volumes of nitrogen gas into the pleural space to slowly neutralize that negative pressure. It collapsed the diseased lung, putting it in a state of splinted rest. So the TB lesions finally had the mechanical stillness required to scar over and heal.
It is stunning that recreating a pathological disease state was considered a mainstream cure. Like they were deliberately collapsing lungs across Europe and North America by the tens of thousands.
They were. Artificial pneumothorax, or collapse therapy, was a standard cornerstone of pulmonary medicine for roughly 60 years. Whole sanatoriums were dedicated to managing these air refills.
Wow.
It only faded into history when we developed pharmaceutical tools that actually targeted the bacteria. Antibiotics like streptomycin in 1943 and isoniazid in 1952. But for over half a century, mechanical manipulation of the pleural pressure gradient was the best weapon we had.
So if Forlani was intentionally breaking the seal by injecting gas, what triggers this physical seal to break when we aren't trying to collapse a lung? Because looking at the sources, it's not always a traumatic injury like a car crash or a broken rib puncturing the tissue. It happens to demographic groups you would just never suspect.
Right, let's look at primary spontaneous pneumothorax. The classic epidemiological presentation, and this is backed by decades of population data, is a tall, thin male in his late teens or 20s who has entirely structurally normal lungs.
But why specifically tall and thin? What does height have to do with lung mechanics?
It comes down to gravitational stress gradients. In a taller, more elongated chest cavity, the lung tissue is stretched vertically.
Okay.
This creates a much stronger negative pressure gradient, pulling at the very top, the apex of the lung, compared to the base. So, over years of this heightened mechanical stress, the tissue at the apex can weaken, forming these tiny, blister-like structures called blebs.
Blebs.
Yeah, blebs. And if one of those fragile blebs ruptures, air leaks directly out of the lung tissue and into the pleural space, instantly breaking that liquid seal.
And reading through the research, smoking is a massive accelerant for this process, right?
Oh, it multiplies the risk exponentially, up to a 10-fold increase in men. Smoking degrades the structural proteins in the lung, specifically elastin and collagen.
So it's breaking down the rubber band.
Exactly. It induces an inflammatory response that fundamentally weakens the tissue architecture. So even if a 22-year-old's lung looks perfectly clear on an X-ray, the microscopic tissue is frail, making those apical blebs far more likely to pop under pressure.
Here's where it gets really interesting, though. We have the tall, young guys dealing with mechanical stress, but there's another variation that perfectly highlights how strange the human body can be. Catamenial pneumothorax.
Yes, it is a rare but exceptionally well-documented phenomenon. We see women of reproductive age developing spontaneous lung collapses that cluster with eerie predictability, almost always within 72 hours of the onset of menstruation.
How on earth is a lung collapse mechanically tied to a menstrual cycle?
Through thoracic endometriosis.
Mm.
Endometrial-like tissue, which typically lines the uterus, somehow migrates and implants on the diaphragm or the pleural membrane itself.
Yeah.
And this ectopic tissue responds to the body's circulating hormonal cycle, just like the uterine lining does.
Oh, wow.
So when hormone levels drop, this tissue breaks down, creating microscopic defects or holes in the pleural barrier. Air slips through those defects and the lung collapses.
Which perfectly demonstrates that a pleural space issue isn't always a lung problem at all. I mean, the lung tissue itself is totally fine, but the anatomical environment around it is being hijacked by hormones.
Yeah, the lung is just the innocent bystander in that scenario. But the most dangerous hijacking of that anatomical environment, without question, is a tension pneumothorax.
Right. This is the classic, terrifying emergency you always see portrayed in trauma bays on medical dramas.
And for very good reason. In a simple pneumothorax, a little air gets in, the pressure neutralizes, and the lung partially deflates. The situation is stable.
Okay.
But in a tension pneumothorax, the rupture in the tissue acts like a mechanical one-way valve. When the patient inhales, negative pressure draws air from the torn lung into the pleural space. But when they exhale, the tissue flap slams shut.
So the air can't get out.
The air is completely trapped.
So with every single breath they take, more and more air gets packed into that confined space, and the pressure just continues to escalate.
Right? Unchecked pressure inside a closed vault.
Yeah.
And that pressure doesn't just crush the affected lung. Once it runs out of room on that side, it starts pushing the mediastinum, the dense central compartment of the chest containing the heart, the great vessels, the trachea. It pushes all of that over to the opposite healthy side.
Which physically kicks the major veins trying to return blood to the heart.
Specifically, the superior and inferior vena cava. If those massive, low-pressure vessels get squished, venous return to the heart just plummets.
Wow.
If blood can't get into the heart has nothing to pump out to the brain or the body. This is obstructive shock. The patient doesn't die because they can't oxygenate. They die because their cardiovascular system is mechanically choked off. It is rapidly fatal.
And the immediate dramatic fix for this is plunging a decompression needle into the chest to vent the trapped air. But the modern trauma sources point out a really significant evolution in where exactly doctors are putting that needle.
Yeah, if we connect this to the broader evolution of patient demographics, classic medical teaching for decades dictated placing that emergency needle in the second intercostal space, right up near the collarbone on the front of the chest.
Right.
But recent trauma literature strongly advocates moving the target down to the fifth intercostal space, on the lateral side of the chest, under the armpit.
Just because the needles simply weren't reaching the air pocket anymore.
Exactly. Chest wall thickness has changed significantly. In modern adult populations, the layer of muscle and adipose tissue at that upper anterior chest site frequently exceeds the length of a standard 5-centimeter decompression needle.
So it just gets stuck.
Right. If the needle bottoms out in the muscle and never breaches the pleural space, you have invented the pressure and the patient still dies.
And even when the needle is perfectly placed and you hear that hiss of escaping air, you haven't actually cured the underlying structural failure.
No. And that is a critical point to clarify. A needle decompression is a temporizing measure. It buys you minutes. It merely converts a lethal tension pneumothorax back into a simple pneumothorax.
Okay, that makes sense.
But the one-way valve, that hole in the lung tissue, is still there. If you don't follow up immediately with a large surgical chest tube to continuously evacuate the incoming air, the tension physiology will rebuild itself within moments.
Okay, so if air breaking the seal creates this escalating mechanical nightmare, what happens when the pleural space fills with fluid instead? A pleural effusion.
Well, the macromechanism of lung collapse is identical. An invading volume takes up limited space and mechanically pushes the lung tissue away from the chest wall.
Right.
But diagnosing why that fluid is there requires a totally different investigative approach.
Because fluid can mean 100 different things. Up until the 1970s, doctors were essentially looking at a vial of chest fluid and making educated guesses, correct? Like trying to eyeball if it looked like heart failure fluid or cancer fluid.
Yeah, it was heavily subjective. But that changed in 1972 when a pulmonologist named Richard Light published objective biochemical criteria.
Light's criteria.
Exactly. He created a specific testable formula comparing the protein levels and an enzyme called LDH in the pleural fluid against the levels in the patient's own blood.
I want to pause on LDH for a second. Why does looking for an enzyme tell you anything about a lung collapse?
So LDH, or lactate dehydrogenase, is an enzyme that lives inside your cells, helping with energy production. It belongs inside the cell membrane. If you find high levels of LDH floating freely in the pleural fluid, it means cells are being damaged, bursting open, and spilling their internal contents.
Oh, wow.
It's literally a chemical distress signal indicating intense local inflammation or tissue destruction.
So Light's criteria used these markers to divide all effusions into two distinct categories.
Right. Transudates and exudates. A transudate is a pressure problem. The fluid is thin with low protein and low LDH. It happens when the heart is failing and backing up hydrostatic pressure in the plumbing, pushing clear fluid across an otherwise healthy pleural membrane.
Okay.
But an exudate is a membrane problem. The fluid is thick, packed with protein and LDH, because local infection, inflammation, or metastatic cancer is physically damaging the pleural membrane, making the biological pipes leaky. Those criteria are still the global standard today, virtually unchanged for over 50 years.
Which is an eternity in modern medicine.
I know.
But speaking of diagnosing the source of the fluid, we really have to talk about Meigs syndrome, described in 1937, because this is the ultimate diagnostic trap.
It truly is. A patient presents with a benign ovarian fibroma, a pelvic tumor, along with ascites pooling in their abdomen, and a massive pleural effusion crushing their lung.
I mean, if you see a tumor in the pelvis and fluid spreading all the way up into the chest cavity, every instinct says this is end-stage metastatic ovarian cancer that has aggressively spread.
Right, the clinical picture looks grim. But in Meigs syndrome, the pathology is entirely benign. The pelvic tumor is completely harmless.
Then where's the fluid coming from?
The ascites fluid in the abdomen is actually being drawn upward into the chest cavity through microscopic, naturally occurring defects in the diaphragm. The negative pressure we discussed earlier, that constant suction in the chest, it literally vacuums the fluid out of the abdomen and into the pleural space.
So it's just fluid following the path of least mechanical resistance.
Exactly.
And the punchline to this whole terrifying presentation is that if a surgeon simply removes the benign pelvic tumor, the abdominal fluid stops forming, the chest fluid completely resolves on its own, and the patient is functionally cured.
It's a vivid illustration of a core medical principle, which is that a pleural effusion is merely a sign, not a final diagnosis. The exact same mechanical finding, fluid compressing the lung, can mean advanced malignancy, basic plumbing backup from a tired heart, or a bizarre but completely curable benign anomaly.
But if I'm analyzing this purely logically, I'm thinking, if you see fluid crushing the lung and compromising breathing, shouldn't you just drain it immediately every single time? Just get the fluid out so the lung can re-expand?
It seems like common sense, but the physiology demands a more nuanced approach. Small transudative effusions, the kind caused by heart failure backing up the pressure, will often completely reabsorb if you just treat the underlying pump.
Oh, really?
Yeah, if you give the patient diuretics, the heart function improves, the systemic pressure drops, and the pleural membranes just pull the fluid back into the bloodstream.
You never need to subject the patient to the risk of a needle in the chest unless the fluid volume is massive, causing respiratory distress, or you genuinely don't know if it's an exudate hiding an infection.
Wait, you're telling me after over 200 years of stethoscopes and modern imaging, the medical community still debates basic things like when to drain a lung? Oh, the debate is fierce and actively evolving. Take pneumothorax, for example. Right now, there is a massive unresolved schism in the international guidelines regarding how to even measure the size of a collapsed lung.
And that matters because
Because it directly dictates whether a patient gets an invasive procedure or gets sent home to rest.
Ah, right, the British guidelines versus the American guidelines.
Exactly the issue. The British Thoracic Society dictates that a large pneumothorax is one with a visible rim of more than 2 centimeters between the deflated lung edge and the chest wall on a standard X-ray.
Okay.
But the American College of Chest Physicians argues a large pneumothorax requires a 3-centimeter rim.
Wait, a 1 centimeter difference in a visual estimate dictates whether a patient gets a needle jammed between their ribs or is told to just go home and take it easy? How is there no global consensus on a single centimeter?
Because we're trying to measure a 3-dimensional volume loss on a 2-dimensional flat X-ray image. The geometry is incredibly tricky.
Right, because the lung isn't flat.
Exactly. The lung is somewhat spherical. And the formula for the volume of a sphere relies on the radius cubed. The volume loss is cubic, not linear. So a seemingly small 2-centimeter rim of air on a flat X-ray actually represents a massive 3-dimensional loss of functional lung tissue.
That makes total sense when you put it like that.
Right, but because of this guideline discrepancy, the exact same patient could walk into a hospital in London and be prepped for needle aspiration, and then walk into a hospital in New York and be told, it's small enough, we're just going to observe you.
That is baffling. So what does this all mean? I mean, the whole just observe you philosophy has gained serious data-driven ground recently, hasn't it?
It has revolutionized the conversation. In 2020, a landmark Australian randomized trial published in the New England Journal of Medicine shook the entire field of pulmonology.
What did they find?
They took patients with moderate to large spontaneous pneumothoraxes and divided them into 2 groups. One group got the standard interventional chest tube. The other group received conservative management, meaning doctors just watched them, gave them oxygen, and waited.
They literally did nothing to fix the air leak.
Nothing invasive. They let the body's own pleural membrane slowly reabsorb the trapped gas over days or weeks. And the data proved that observation was non-inferior to invasive intervention.
Wow.
It overturned decades of reflexive clinical muscle memory, where doctors were taught, I see a large pocket of air, I am obligated to place a tube.
It's fascinating how modern medicine is increasingly recognizing that sometimes doing less and trusting the physiology is actually better, especially when trying to fix things too fast can trigger a catastrophe.
Yes, and this brings us to one of the most feared complications in pulmonary medicine, and why draining fluid or air requires immense respect for the tissues involved. Re-expansion pulmonary edema.
Re-expansion pulmonary edema. This sounds intensely dangerous. What exactly is happening here?
Imagine a patient has a massive pleural effusion, say 2 liters of fluid, that has been crushing their lung for 3 weeks. If a doctor places a drain and rapidly sucks all 2 liters out in 10 minutes, that chronically squished lung suddenly springs violently open to fill the void.
The mechanical tug-of-war instantly resumes.
Yes, but the tissue isn't ready for it. This abrupt, aggressive reinflation triggers a massive inflammatory response. It's a form of reperfusion injury.
Okay.
The microscopic capillaries in the newly expanded lung tissue panic and become highly permeable. They leak like sieves. Fluid rushes out of the bloodstream and directly floods the tiny air sacs of the newly expanded lung segment.
So wait, you successfully clear the fluid from the outside of the lung, only to cause the patient to actively drown in their own plasma on the inside of the lung.
Exactly. The systemic shock can be so profound that a stable patient ends up intubated in the intensive care unit.
That is horrifying.
This is why strict modern protocols cap fluid drainage at roughly 1.5 liters per session. It's a sobering reminder that the treatment itself becomes a life-threatening emergency if you don't respect the delicate timeline of the physiology.
Okay, let's take this incredible tension out of the hospital and look at how this invisible tug-of-war affects you the next time you leave your house. Because this mechanical balance dictates what you can and cannot do, primarily thanks to Boyle's law.
Boyle's law dictates that there is a strict inverse relationship between the pressure of a gas and its volume. If the ambient environmental pressure drops, a trapped pocket of gas will universally expand to equalize.
So we've established that just a tiny pocket of trapped air can ruin this whole equilibrium. But what happens if the pressure outside your body suddenly drops? Say you're ascending in a commercial airliner.
Right. Commercial airlines strictly require patients who have suffered a recent pneumothorax to wait roughly 2 to 3 weeks and have radiographic clearance before flying. Even though commercial cabins are artificially pressurized for our comfort, the pressure inside the cabin at cruising altitude is still significantly lower than the atmospheric pressure at sea level.
So if you have even a microscopic, completely asymptomatic bubble of air still trapped in your pleural space, the drop in cabin pressure forces that bubble to expand.
And that physical expansion can tear the healing lung tissue, provoking a brand new massive lung collapse while you're trapped in an aluminum tube at 30,000 feet.
Oh, wow.
Scuba divers face the exact mirror image physical risk. As a diver ascends from the high-pressure depths of the ocean back to the surface, ambient pressure drops rapidly.
Which is why the cardinal rule of diving is to never, ever hold your breath when surfacing.
Exactly. If they hold their breath or if they have weakened pulmonary tissue that traps air, that expanding gas has nowhere to go. It will rupture right through the lung wall and directly into the pleural space, causing an immediate pneumothorax underwater.
Okay, before we wrap up, I want to leave you with one final thought to mull over. We've spent this entire deep dive unpacking how our fundamental ability to breathe, to draw oxygen into our bodies and stay alive, relies entirely on a microscopic 10-milliliter layer of fluid maintaining a highly precarious tug-of-war between two opposing physical forces.
It is essentially a lifelong biological tightrope walk.
It really is. So it makes you wonder, what other perfectly balanced, utterly invisible mechanical systems inside our bodies are currently operating flawlessly, but are just one tiny pressure shift away from total collapse?
It definitely forces a deep appreciation for the quiet, elegant engineering keeping us functioning every second of the day.
It really does. Thank you so much for joining us for today's deep dive into the pleural space. Keep asking questions, keep looking beneath the surface, and we will catch you next time as we unpack the next complex medical mystery.